Welcome back to Mastering Medical, Part 4 of our Pulmonology Rapid Review. This one is the emergencies, and the pattern that runs through it is that the exam is testing whether you can pick the right intervention in seconds, not whether you can name the disease. Two of these pairs are decided by a stethoscope alone. Let's start there. First, the pneumothorax spectrum. A trauma patient has absent left breath sounds, hyperresonance, hypotension, distended neck veins, and worsening distress. All three of these are air in the pleural space. The question is what that air is doing. Is it merely present? Is it communicating with the outside? Or is it pressurized? A simple pneumothorax is air in the pleural space with stable vitals and no mediastinal shift. Primary spontaneous cases are classically a tall, thin young man from a ruptured apical BLAB. Secondary cases occur in existing lung disease like COPD. An open pneumothorax has a chest wall wound communicating with the pleural space, the sucking chest wound, and it is dressed with an occlusive dressing taped on three sides so air can escape but not enter. Tension pneumothorax is the emergency. A one-way valve lets air in and not out, pressure climbs, and it compresses the mediastinum, kinking venous return. That is why it produces obstructive shock, hypotension with distended neck veins, along with absent unilateral breath sounds, hyperresonance, and tracheal deviation away from the affected side. The critical exam point is management. Tension pneumothorax is a clinical diagnosis, so you perform immediate needle decompression followed by a chest tube. If an answer choice says get a chest x-ray first in a hypotensive patient, it is wrong. Now the pair that follows directly from that. After chest trauma, a patient has hypotension, distended neck veins, muffled heart sounds, and pulsus paradoxus. Both tamponade and tension pneumothorax cause obstructive shock with hypotension and raised neck veins. Listen to the chest before you decide where to put the needle. Cardiac tamponade is fluid in the pericardium compressing the heart. Beck triad is hypotension, distended neck veins, and muffled heart sounds. Add pulsus paradoxus, an inspiratory fall in systolic pressure of more than 10 millimeters of mercury, and on the ECG, low voltage with electrical alternance as the heart swings in fluid. The treatment is pericardiocentesis. Tension pneumothorax gives you the same hypotension and the same distended neck veins, but the chest tells you the difference. Breath sounds are absent on one side and that side is hyperresonant, the opposite of the dullness you would find with fluid. Tracheal deviation is real but late, so do not wait for it. The treatment is needle decompression. Both are obstructive shock, both raise the jugular venous pressure, and the stethoscope separates them in about 5 seconds. Muffled heart sounds means go to the pericardium. Absent breath sounds with hyperresonance means go to the pleura. Now, two conditions that share a name and almost nothing else. A premature newborn develops grunting, retractions, and diffuse reticulogranular lungs shortly after birth. Both stiffen the lung and both flood the alveoli. The question is whether surfactant was never made or whether it was destroyed. Neonatal respiratory distress syndrome is a manufacturing problem. Type 2 pneumocytes are immature before about 34 weeks, so surfactant is never produced. Surface tension stays high and the alveoli collapse. Risk is prematurity and also being the infant of a diabetic mother, because fetal hyperinsulinemia delays surfactant maturation. Imaging shows diffuse ground glass or reticulogranular lungs with air bronchograms and low lung volumes. Prevention is antenatal corticosteroids, treatment is exogenous surfactant, and a lecithin to sphingomyelin ratio below 2 predicts immaturity. Acute respiratory distress syndrome is a destruction problem. An insult, sepsis, aspiration, pancreatitis, trauma, or transfusion triggers diffuse alveolar damage. The alveolar capillary membrane leaks protein-rich fluid and surfactant is inactivated. The Berlin criteria are onset within 1 week, bilateral opacities, not fully explained by cardiac failure or fluid overload, and a ratio of arterial oxygen to inspired oxygen fraction below 300. Both show hyaline membranes histologically, which is why the names rhyme, but the mechanisms are opposite. Manage ARDS with low tidal volume ventilation, around 6 milliliters per kilogram of ideal body weight, which is one of the few interventions proven to reduce mortality. Last pair. A patient with recurrent unresolved pulmonary emboli develops pulmonary hypertension with mismatched perfusion defects. The 5 groups look like pure memorization, but they are not. Name the cause first, and the group falls out on its own. Pulmonary hypertension is a mean pulmonary artery pressure at or above 20 millimeters of mercury on right heart catheterization. Group 1 is pulmonary arterial hypertension, meaning the small pulmonary arteries themselves are diseased. It is defined by a normal pulmonary capillary wedge pressure at or below 15, with a pulmonary vascular resistance above 2 Wood units. Causes are idiopathic, heritable through BMPR2 mutations, connective tissue disease, especially scleroderma, HIV, portopulmonary hypertension, appetite suppressants and methamphetamine, and congenital heart disease. Groups 2 to 5 are secondary and named by the upstream cause. Group 2 is left heart disease and is the most common of all. And the giveaway is an elevated wedge pressure because the pressure is backing up from a failing or stenotic left side. Group 3 is lung disease and hypoxia, COPD, interstitial lung disease, and sleep disordered breathing. Group 4 is chronic thromboembolic disease, which is the one worth spotting because it is potentially curable with pulmonary endarterectomy. Group 5 is unclear or multifactorial, including sarcoidosis, sickle cell disease, and end-stage renal disease. So the single most useful number is the wedge pressure. Normal means the artery, elevated means the left heart. Let's lock it in. Tension pneumothorax is a clinical diagnosis, so needle decompression comes before the chest film in a hypotensive patient. Tamponade and tension both give hypotension with distended neck veins, and the stethoscope separates them. Muffled heart sounds versus absent breath sounds with hyperresonance. And neonatal respiratory distress syndrome is surfactant that was never made, while acute respiratory distress syndrome is surfactant destroyed by inflammation. For acute respiratory distress syndrome, low tidal volume ventilation at around 6 milliliters per kilogram of ideal body weight is the intervention that changes mortality. For pulmonary hypertension, a normal wedge pressure means group 1 arterial disease, while a high wedge means group 2 left heart disease. And the habit for this video: in obstructive shock, listen before you choose the needle. That is part 4. Part 5 closes the series with lung cancer, the apical and mediastinal syndromes, sleep apnea, and altitude illness. See you there.